introduced our distinguished presenter, Dr. Lena Mittal. I've known Lena for a long time. She's a perinatal psychiatrist and has several leadership roles, including she's the chief of the Division of Women's Mental Health at Brigham and Women's and instructor in psychiatry at Harvard Medical School. And she's also the program director for the Women's Mental Health Fellowship. She is also on our MCPAP for Moms leadership team as the associate medical director. She also, very in line with the topic for today, she co-chairs along with Gina Gallagher our DEI committee, our Diversity, Equity, Inclusion Committee within MCPAP for Moms, and has really been instrumental and provided wonderful leadership for our program in thinking about how can our program move forward in promoting equity both within and among all the individuals that we're serving throughout our services. She has a lot of publications, speaks nationally, and is an expert both in perinatal mental health, substance use disorders, and also in health equity. So thank you for presenting today, Lena, and I will pass it off to you.
Thanks so much, Nancy, and thank you all for coming and for taking some time to think a bit about this topic, which is a complex topic. So I'll hope to try to kind of distill what we can and leave some time for a discussion at the end if we can as well. Oh, no, I'm not advancing. Here we go. Just a little bit about some disclosures. I am paid in part through MCPAP for Moms, which is funded by the Department of Mental Health in Massachusetts. I have done a little bit of consulting work with Sage Therapeutics, so unrelated to the content of this presentation. If at any point I sort of bring up any case contents, it will be composite without identifiable information, and I won't be discussing any off-label medication use. And then I always think it's important just to pause a little bit. We talk about our disclosures in a really systematic way, but I think there's another aspect of disclosure, which is to think a little bit about our own identities and roles. And so I identify as a cisgendered South Asian woman. I identify as a woman of color. I have many roles in this world. I'm a psychiatrist, I'm a mother, I'm a wife, I'm a friend, I'm a leader. And it's really important to think about talking about the perspectives from which we're presenting or we're thinking about these topics in particular. Our roles and identities are intersectional as well. So I am, for example, a working mom, or I am a lot of, my roles will then intersect and then become a unique experience related to the intersectionality of those roles. And so I'm speaking today from that perspective. And I also just want to think a little bit about the notion of disclosure around these topics. And so especially as myself, I identify as a woman of color, I think about disclosing and talking about racism in the context of personal experiences related to racism and personal experiences related to sexism or other forms of discrimination. And in thinking about disclosure and talking about these topics, we're often really revealing an important part of ourselves. And so just to keep that in mind when we're talking about race, ethnicity, inequity, discrimination, bias, structural racism, these are all this is a lens from which I'm bringing this. So today I'm hoping to talk a little bit about some key concepts in maternal health and racial equity, to look at racial inequities in screening, referral, and treatment of mental health and substance use conditions. Today I'll focus mostly on depression and opioid use disorder. Identify at least one impact of structural interpersonal racism and maternal mental health inequities, and then describe some strategies to address inequities and create an anti-racist environment using trauma-informed care principles. So a couple of key concepts that I think are important to sort of level set around at the beginning of this conversation. Structural racism, I'm operating from a definition that defines it as racist processes embedded in laws, policies, and practices of society and its institutions that provide advantages to particular racial groups deemed as superior while differentially oppressing or disadvantaging other groups viewed as inferior. Interpersonal racism is mediated at the level of individuals, discriminatory interactions between individuals resulting from differential assumptions about abilities, motives, intentions, and value, essentially, and differential actions towards others based on race or identity. I will at various times use the acronym BIPOC just to define that at Black and Indigenous people of color. in a lot of conversations around racial equity, we talk about implicit bias. Just to define that, social stereotypes about certain groups of individuals that people hold outside of their conscious awareness that may be sort of ingrained, or implicit or unconscious might be another word for this term. And to kind of drill down a little bit, unconscious or implicit bias is really sort of contrasted with discrimination, which is puts a bit more of the onus on the person holding the bias in some ways, treating someone more or less favorably based on the group or class they belong to, related to biases, prejudices, stereotyping, and can manifest in a variety of ways. And then at the end, we'll talk a bit about racial trauma, race-based stress, which really referring to the harm related to the experience of racial discrimination. And in the form of harm, threats of harm, humiliation, and witnessed harm. So sort of the totality of the experience of exposure to racism, and then the accumulated trauma and stress. But to take a step back, we're all here in part because the work that we do at MCPAP for Moms, the work that many of you may be interested in doing or already doing, is related to maternal mental health. Affecting the perinatal individual, the child, the family that are impacted. We know that there are broad and deep consequences to maternal mental health conditions, including differential engagement in medical care, increased risk for smoking and substance use, increased obstetric complications, challenges in lactation, bonding, relationships, family relationships, partner relationships. Certainly most catastrophically, we are concerned about risk of maternal mortality related to suicide and overdose. And then for the child, eventually exposure to maternal mental health conditions can increase risk for cognitive delays and growth issues and behavioral problems and mental health conditions themselves. And mental health conditions, as we think about sort of perinatal individuals, are seen through data compiled from maternal mortality review committees throughout the US as being a leading cause of pregnancy-related death. And to define this, actually, mental health conditions include mental health and substance use disorders, which is in part how we at MCPAP for Moms also think about mental and behavioral health in the perinatal population. And this is a sort of story and understanding that we have now, that in our country, we are really not serving all perinatal and birthing individuals well. We have rising maternal mortality overall, but differentially impacting, overwhelmingly inequitably impacting individuals of color. And so these are data sort of overall for all pregnancy-related deaths, not specific to substance use or mental health conditions, but in thinking about sort of the inequities, this is pretty stark data that Black women and Native and Indigenous women are 4 and 3 times more likely to experience or to be affected by pregnancy-related death as compared to white women. But beyond the sort of catastrophic outcome of maternal mortality, we're also becoming increasingly aware of racial and ethnic inequity that impacts perinatal outcomes broadly. Pregnant women of color are more likely to experience preeclampsia and lower birth weight. There are racial and ethnic inequities and disparities in frequency of labor induction, episiotomy, cesarean delivery. Non-Hispanic Black women have higher rates of postpartum hemorrhage and infection and thromboembolic disease. Preterm birth rates are higher for Black women as compared to white, and individuals who identify as Latina or are more likely to receive or less likely to receive epidural analgesia, especially in the context of not having English as a first language. And one of the sort of core tenets of the work that MCPAP for Moms does is really trying to promote mental health, universal mental health screening among perinatal individuals in health settings, in particular in women's health care settings, in particular perinatal healthcare settings. But what we see is as things stand now, and in the recent history, there are clear racial inequities in maternal mental health screening, despite there being recommendations from a number of bodies around universal screening. There is differential implementation of screening practices. Black, non-Hispanic, Hispanic, and Asian non-Hispanic, as well as Native American and Indigenous women are screened less frequently for perinatal depression as compared to their white counterparts. In one study, it was important to note, though, that the most utilized screening tools in these settings are effective in identifying major and minor depression. In this one study in particular, it was among Black women in Baltimore City. But it's important to recognize that while we have tools that are effective, we are not using them in an equitable way. When individuals of color are screened for mental health conditions in perinatal settings, it is notable that the odds ratio for a Black or a Hispanic woman as compared to a white woman to experience depressive symptoms or to be diagnosed with depressive symptoms in the context of screening is about 2 to 1 as compared to white women. In one study, 44% of African American women and 48% of Hispanic women showed symptoms of depression as compared to white women in that particular setting, which was a relatively large survey study. And then beyond the screening, sort of the question is what happens after a mental health condition or mental health symptoms are identified. What we see is that referral and retention in treatment for perinatal mood and anxiety disorders is also impacted by racial inequity. So as compared to white women in one study, Black women were less likely to enter into care. Latina and Black women, as identified in the study, were less likely to continue in care, and were also less likely to refill a prescription once one was written. And it's important to think about what are the barriers to engaging in care. This is not just about, again, sort of looking at sort of the experience of BIPOC individuals, there are impacts occurring at all levels, at sort of individual and person-centered levels, including in the context of interpersonal discrimination. There are cultural variations within BIPOC communities, and this is not a monolith. These are a wide variety of people from a wide variety of cultural backgrounds with variation in views of wellness and mental health. And there are often, in one study, for example, in a systematic review looking at ethnic minorities in the UK, there were a lot of concerns about what will people think? What will my social support networks think? What will the presumption of my wellness or my capacity as a parent be? The sort of inherent individual and community level stigma around mental health conditions. Then there are also health system level barriers, thinking about sort of the lack of racial and ethnic concordant providers, operational rigidity, so having health systems that are complex to navigate, that don't have a wide variety of hours or accessibility, or providers who speak all of the languages that the patients that they serve may need, especially specific to mental health care. And then the complexity around mental health parity in general. There's lack of coverage or inadequate coverage for mental health services, and then other support services. So for example, doula services and other things that we know can really, really help improve outcomes for BIPOC individuals. There's a lot of challenges in gaining coverage, insurance coverage, and so on. Structural barriers are profound and contribute to challenges in engaging in mental health and substance use care, inadequate parental leave policies, and criminalization of mental health and substance use disorder in perinatal individuals. And so to transition a little bit in thinking about just substance use disorder in general. We're thinking often about maternal mortality, but I think if we take a step back and look at sort of who is impacted by mortality in the context of opioid use, we have some really, really powerful data here in Massachusetts from our colleagues in the Department of Public Health, looking at overall opioid overdose deaths. And we've been monitoring closely, and in 2020, we saw in almost all populations an increase in opioid overdose death, but in particular in populations of color. So in Black, non-Hispanic men, we are seeing an increased rate of opioid overdose death in Hispanic men and Asian men. And then also in Black, non-Hispanic, and Hispanic females, we're also seeing an increased rate of death by opioid overdose. And this is where we are sort of noticing the impact of inequitable access to care, screening, and availability of life-saving treatment. So if we're looking at the perinatal population, opioid overdose does remain a leading cause of maternal mortality. And in data, again, from really amazing work through our Massachusetts Department of Public Health and colleagues, there's been a really clear pattern that medications for opioid overdose, opioid use disorder are really, really impactful, but also the pattern of risk of opioid overdose in pregnancy really reflects both an opportunity and challenge and risk. In the context of pregnancy, the risk for overdose decreases over time through pregnancy and then increases again in the postpartum period. And what we know is that treatment for using medications for opioid use disorder can save lives, and that we have the ability to really decrease this risk of death significantly at nearly all time points. But what's really also quite clear increasingly in our perinatal population impacted by opioid use disorder is that Black, non-Hispanic, and Hispanic women are less likely to receive medications for opioid use disorder as compared to white women. And also, when prescribed medications for opioid use disorder, women of color are more likely to receive methadone than buprenorphine, which can have really important clinical implications. As we know, buprenorphine, owing to its mechanism as a partial agonist, actually has significant ability to decrease risk of death by overdose as compared to methadone, which is a full agonist. And so looking again at a potential sort of mechanism for the impact around rising maternal mortality in the context of mental health and substance use conditions. So sort of taking all this together, it's important to sort of turn our attention to thinking about what's driving all of this. What are the impacts of these racial inequities, and what are driving these racial inequities, and how do we think about how we as a system can better address racial inequity in our individual settings as clinicians, but also more broadly in the system. And I think what makes it, what's most helpful in thinking about addressing inequity is to take a trauma-informed lens. And so first we need to define trauma. So trauma is defined as an event or series of events or set of circumstances experienced by an individual as physically or emotionally harmful or threatening, and has lasting adverse effects on individuals' functioning in physical, social, emotional, or spiritual well-being. And so part of this is witnessing these events. It's not just experiencing oneself, but also experiencing a set of circumstances or witnessing circumstances that can be traumatic. And experiences of trauma are widespread. The majority of individuals broadly, sort of looking at the general population, will have an exposure to some kind of traumatic event. But racial trauma specifically is a particularly pervasive experience among BIPOC individuals. Again, looking at interpersonal, structural, and community aspect of racial trauma. And when we think about kind of the cumulative experience of trauma, we think sort of a bit to the concept of adverse childhood experiences, or ACEs. So there are adverse childhood experiences and adverse community environments, and they sort of taken together really impact the cumulative risk that people can acquire over the lifetime. So adverse childhood experiences include direct exposure to violence, substance use, emotional abuse, parental mental health conditions, neglect, homelessness, food insecurity, these sort of complex experiences an individual may experience related to their specific context. But then if we think about a tree, and so in the soil of that tree, there may be the community adversity. So exposure to poverty, discrimination, community disruption, community violence, housing instability, lack of opportunities and mobility, and nutrition, and so on. And when we think about all of these impacts together, racism really can be thought of as a cause of trauma and a mechanism for toxic cumulative stress, a mechanism that Adeline Geronimus coined as the term weathering. And the weathering hypothesis is, in the original paper defining this context, she said, the health of African-American women may begin to deteriorate in early adulthood as a physical consequence of cumulative socioeconomic disadvantage. And what she began to observe now nearly 40 years ago, or began to describe rather, was that this cumulative deterioration in health, the inequity widened with age. And so this chronic stress was sort of attributed in context to the lived experience of racism, discrimination, and continuous allostatic load of stress. There's the sort of concept of stress being taken together across domains, across body systems, to really be a cumulative experience for the body. And racial inequities in health outcomes persist when even controlled for in studies, controlling for social and economic factors. And so there is what's described this kind of explicit and specific persistent toxic stress associated with the exposure to racism and discrimination. Chronic studies link chronic stress from trauma to lower rates of lower birth weight in non-Hispanic Black women, for example. So that's a specific impact in the perinatal space, but we see these same impacts on cardiovascular health, on neurologic health, on a variety of systems. Now, the experience of racial trauma itself is pervasive. And in speaking about BIPOC individuals, I wanted to also be sort of cognizant of the fact that that includes the concept, the experience of discrimination that are experienced by Asian American and Asian individuals here in America. In particular, in the context of the COVID-19 pandemic, the rates of anti-Asian discrimination, hate, violent acts has skyrocketed. In one study conducted by colleagues at my institution, the Brigham, as well as Mass General, and through an organization called Stop API Hate, investigators found through a survey study that 68% of respondents, including of Asian and Asian American individuals in the United States, reported increased experiences of discrimination in the context of Asian identity in the first wave of COVID-19. And this discrimination was associated with a significant increase in PTSD symptoms. In the Black community, the majority of Black individuals will report that they face discrimination. But interestingly, there's an increase in the subjective experience and describing the personal experience of discrimination among those who report having college experience as compared to a high school education. In our state, the PRAMS survey demonstrates similar patterns in perinatal and birthing individuals. In the PRAMS data, in the most recent PRAMS data, the investigators looked at the specific experience of discrimination in white non-Hispanic individuals as compared to Black non-Hispanic birthing individuals, and in all domains contributing to stress in daily life, emotional upset, physical symptoms, and the experience of constantly thinking about race, there's a significant difference in the experience of race and racism among Black birthing individuals. This experience persists despite differences in education, and in fact widens with higher educational completion. The thought being this may increase the experience of othering and separateness in settings where there is less and less peer support. And this is not just specific to US born, but in fact, in non-US born as well as US born Black individuals, we're seeing the same disparity in terms of experiencing discrimination and stress related to nativity. So if we're thinking about all of this experience of trauma through racism and the allostatic load of discrimination, it's important to think about how can we as a system rethink how we're doing things and engage our teams and ourselves in an approach to taking a trauma-informed lens to what our patients are experiencing, what our colleagues are experiencing, what our community is experiencing. And so I'll sort of turn our attention to thinking about the 6 core principles of trauma-informed care, which can really guide how we think about working towards racial equity in healthcare as much as trauma related to other experiences. So the main core principles: safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, sort of a laterality in decision making, and then acknowledgement of the cultural, historical, and gender context in which all of the care that we're providing is being received, are the core principles of trauma-informed care. One group of trauma-informed care experts coined the 4 R's as a strategy for implementing the principles of trauma-informed care. And so thinking about how we might apply that to the perinatal setting, the first R, realize. So realizing that trauma is a pervasive experience and may predate the pregnancy and perinatal care experience. Recognizing that the signs and symptoms of prior trauma may emerge in the context of perinatal care, that it is incumbent upon us to respond through language and actions that demonstrate a trauma-informed approach, and that our goal is to resist re-traumatization, to minimize stressors, to maximize empowerment and empathy and transparency in care. And then I sort of flag the context of resilience because I think resilience is an important protective factor that people may have, but I think the question is, do we want to rely on a system that traumatizes people and then draws forth resilience versus limiting the trauma in the first place? And so while resilience is helpful to people, not everybody has equal access to resilience either, and we should be thoughtful about that as well. So when we think about how we can start to think about our care and how we as providers can start to create a path towards equitable care, what we see over and over again when we're working with in populations where there are ethnic disparities related to ethnic differences or racial differences, is that enhanced screening and timely treatment is necessary. And we can achieve that through universal screening for mental health conditions. Additionally, developing perinatal care programs and standardized postpartum follow-up to reduce barriers. So perinatal care management programs can include co-located mental health services. They can include a variety of services, so not just the medical services, behavioral health services, home support services, home visiting services, lactation support, doula services, really comprehensive care settings. Important to also emphasize programs that highlight culturally responsive birth support, so doula programs, and culturally responsive birth planning. So this is one tool here, and I'll focus on that a little bit towards the end for guiding conversations around perinatal care preferences. Trying to engage with, connect patients with, and include in our workforce culturally representative providers. So over and over again in qualitative studies around mental health care and women's health care, patients will report how important it is to have providers that they see some cultural concordance with, whether it's on the basis of race, whether it's on the basis of ethnicity or background or gender. And so increasing representation within the provider workforce is another way to be thinking about a pathway for us overall as care providers to more equitable care. And then thinking about educating ourselves as systems and as individuals around trauma-informed care at all stages of care. So the notion of trauma-informed care really has to include, from the front door through every moment of care, and then back through the hospitalization, through the clinics, through discharge, and so on. So thinking about implementing trauma-informed care from a racial equity lens for all stages of treatment. And then a really wonderful sort of commentary paper came out last year in Health Affairs with some really clear and explicit policy recommendations. And some highlights of that include really looking at our policies. So non-othering policies, how we define families, being inclusive and not focused just on family structures that include two parents of opposite sex, and to really be broad about thinking about family structure and policies that are inclusive, to think about expanding insurance coverage for mental health care, behavioral health care, substance use treatment, as well as increased coverage for postpartum care and child care, and so on. Again, workforce development, paid parental leave, housing and food security policies. So as we think about what we're doing at the level of our care provision and our settings, we also need to be thinking broadly about policy recommendations as well. So what can individuals do in the context of their workplace to become an anti-racist perinatal mental health care setting? Center the voices of BIPOC patients and providers. Amplify and highlight the opinions of BIPOC patients, include BIPOC providers in decision-making, make sure that we're all at the table. For non-BIPOC providers, it's important to engage in a process of reflection, intentionality, and accountability, and have that be part of the culture of the space that we're working in. Acknowledge the existence of racism and the range of reactions. Emphasize self-care, in particular for BIPOC individuals. So really keep having an open, safe space for liberated discussion, but also recognizing that discussions around race and racism are challenging, and self-care is absolutely necessary to be able to engage in a setting where one is minoritized. Social connection and support is absolutely a part of that self-care package, but also creating an anti-racist environment, recognizing that we bring our whole set of experiences to our work setting. And so social connection and support maintains wellness. Collaboration and care is absolutely essential to being an anti-racist perinatal care setting, but really for all good care, having collaborative birth plans, mental health care advanced directives, for example. So what would how do we think about when mental health treatment is necessary? What is that person's definition of mental health and wellness? What is that family able to do to engage in conversations about mental health and wellness in the in pregnancy and postpartum in the context of loss. So thinking about being collaborative in creating care plans and contingency planning throughout all stages of care. And then as a care setting and as a workplace, thinking about empowering resistance, advocacy, and self-care. So giving people space, creating opportunities for advocacy, creating opportunities to engage in self-care together, to make space for people who might need a little more space or care to take that space and not be penalized. There are a couple of really great tools around racial trauma and racial wellness. One is a tool created by some students at Boston College under the hashtag racial trauma is real. There is a lot of actually really great materials through, there's a website and some social media content. I referenced the prenatal and postnatal care preferences conversation tool. This is available through an organization called Loom. It's freely available, but you have to sign up for it. And there's a link to signing up for access to it. It's a really useful sort of conversation starter that is patient facing, but I think providers can really learn from how to kind of talk through different stages of pregnancy care from a racial equity lens. At McPat for Moms, we've created some general self-care tools. We specifically created them in the context of the early days of the pandemic, which seems so long ago now, but really, I think, hold still and maybe useful tools to bring forth in patient contacts or with patients that you're working with to help guide a conversation about self-care or to create an opportunity for them to reflect on what's helpful for them. We also have some provider materials about how to think about sort of mental health promotion in the context of the stress of the pandemic. Again, these are materials we created early in COVID in the pandemic, but still hold and may be useful, especially as you think about people with prior histories of mental health conditions and what may be helpful for them in the context of crisis and stress. I want to thank our really fabulous team for helping support this webinar and the work that we're doing at McPat for Moms around diversity, equity, and inclusion. And just want to spend some time maybe creating some space for discussion. If there are any questions, I haven't been able to look at the chat yet.
Thanks, Lena. I have a question.
Absolutely.
I'm curious to hear how, I don't think we have any questions in the chat yet, but please, does anyone have a question for Lena? I'll ask mine while we wait for people to either enter them into the chat or ask questions. So my question is, I'm curious to hear, so as a psychiatrist, right, we're both psychiatrists, or for some people we may have here, maybe OBs, you're with a patient and you're having a clinical encounter, you've evaluated somebody, and how would you, to sort of thank you for the overview and the of all the content and a lot of great data around some of these disparities, a lot of the inequities, and around a lot of like the concepts that are there and stuff. And you presented some concrete tools as well, which was super helpful. So I'm curious to hear about, we evaluate a patient, we're sitting there with them. How do we what are some words to ask about this? We get asked that on my Pop for Moms team a lot. Like, how do I ask about racial trauma, right? And how do I ask about someone's race and ethnicity? Because I think people feel often uncomfortable with that. So that would be my question. I also see we have another question in the chat too.
Yeah, absolutely. And I think it's really important to think about how to ask, especially if you are not used to talking about race and ethnicity. And I think that was one of the reasons why I sort of was explicit about my identity, is also because it takes some practice to start talking about race and racial identification. And when you bring that conversation into the room, it will then also highlight differences. So if there may be a differential between you and the person that you're talking with about, in the context of race, culture, background. So first, it's important to, we've had to really think about this because we're starting to gather data about the patients that providers are calling us about. And so when we gather that information, we're asking people, how does this individual that you're calling us about self-identify? One of the most important keys in terms of asking about racial and ethnic identity is to not rely on a presumption about appearance or not, or based on a name or based on language or whatever presumptions may happen, but simply to ask, how do you identify on the basis of race? How do you identify on the basis of ethnicity? If in your conversation, you're also trying to gather data about things like sexual identity, gender identity, sexual orientation, you want to just ask explicitly, how do you identify, what pronouns do you use? Ask the person to identify for themselves. And if they, sometimes, our systems are rigid and they only give us a few choices in the drop-down menu, you can engage in a conversation there, give the choices that are available and offer an opportunity for sort of a free response if the choice that the person offers isn't in the list. And so it's really about self-identification. Asking about racial trauma is a different question. So once you sort of established how somebody identifies, it's useful to then ask, can you tell me, have you ever experienced any kind of discrimination on the basis of your race or another identity that you may hold? And I think that just simply opening the door in a really open-ended way about, have you ever experienced discrimination? And then following that up with open-ended questions about, well, how has that impacted you? I think that's a way to sort of get at this. And I think the presumption is that, if you come from a different background than the person has identified they come from, that there may not be a space to have the discussion. But I think opening the discussion up in a way that is inquisitive and in furtherance of their care is not necessarily harmful. It's really about inquiring about their experience, not relying on stereotypes, and also not relying on presumption, but just creating a space. And if the conversation doesn't happen right away, you've opened the door also to say, like, this conversation can happen in an ongoing way.
Thank you. Yeah, that's really helpful. Those are some really nice concrete examples of things. Does anybody else have questions? I see we got something in the chat, so that was excellent. Thank you. I'm glad that you, I agree. And they're asking if we can please share the slides and references. So we will put the slides up online. They will be on our website under the provider and tools. We put our presentation, so we will upload the presentation and I believe the recording as well online. And for the references, I'm not recalling, did the slides have reference? I think you put the references.
Yeah, there are some in the footnotes.
Okay, they're in the footnotes. So yeah, they will be there, and the recording too. So you're welcome to share that. Any other questions? Oh, okay, we have a question here. This may be difficult to answer, but for patients of color who question their safety in a facility with predominantly white providers, do you have any clues on how we can respond to ensure their safety? I'm a person of color myself, and I struggle with a response. That's a great question. Thank you.
It's a really good question, and it is really hard to answer. I think my answer in this context really sort of is rooted in the fact that I think it's really important to acknowledge and be real that we're both as providers who identify as people of color, but also patients who identify from a marginalized community of some, whether it's an identity that's visible or not. We're all sort of experiencing the reality that discrimination and these sort of toxic stress experiences around discrimination are real and that they occur. And so part of it is, I think, not having creating the false expectation that we can then ensure that is not happening at moments that we don't have control of either, and creating space to have the conversations and to talk about it and to think about what will help moving care forward for that individual, while not sort of sugarcoating the fact that they have experienced complexity coming into that encounter and will experience other complexities outside of that encounter. It doesn't sit all on our shoulders as individuals, but really that we're working together to try to create a care environment, acknowledging the realities of the context it's all happening in. I think that's the sort of trauma-informed care piece, which is you collaborate with the person to validate their experiences and to share in their experiences and to make things work for them in that moment as best you can. But the context is part of it. And the context is we live in a place and work in places where discrimination may happen and toxic sort of stressful experiences continue to happen. I don't know if that's helpful or it's just a drag, but it's sort of the reality in my opinion.
Yeah, thank you, Lena. It is a reality. Thank you for that answer. We have another question here. I'm struggling getting providers for mental health care from therapists and psychiatrists to refer to. I think they're asking about, yes, we hear the struggle. It is a major struggle, right? I mean, it's been a major struggle for a long time, but it's an increasing struggle right now with getting providers for mental health care. And I think you're asking about psychiatrists to refer to. Is that what you're, I want to make sure I'm understanding the question. Yes, you're asking about psychiatrists. Want to take that one, Lena? That's another great question. And that's what we're about at McPap for Moms, right? So
yeah, I mean, the reality is, I think, even prior to the pandemic, we wouldn't exist as a program if there were enough providers for everybody to be seen. And so part of what we do is really try to help create opportunities for mental health care to happen in a variety of settings, because there weren't enough mental health care providers prior to the pandemic. And what we've seen is that during the pandemic, both the demand for mental health care has increased. People who are in care are not leaving care as they used to. People are requiring, staying in care, and then providers have sort of some constricted capacity as well with COVID restrictions and so on. It's really changed the way care has been delivered, and there's sort of just an overall kind of logjam as a result in terms of referral. So we saw this even prior to the pandemic, and it's just exacerbated now. So more to validate the experience, what we do at McPap for Moms is we really try to help facilitate searches that are more refined, specific to the needs of the patient. So if you call us, our resource specialists are able to look at insurance and try to have a sense of openings, and we have a database that keeps track of kind of availability, and then also can be searched on the basis of location or language or expertise or particular types of skill sets. And so we can kind of create a refined search and provide you as the provider or the patient directly some resources that are a little bit more curated. But the reality is that even still, we're experiencing challenges in finding resources as well.
Absolutely. Yeah. And we have another question, and we're always can see people for face-to-faces too. So if you're working with someone and you're experiencing challenges in getting mental health care for them, and we do a telephone consultation, we can always see them for a one-time consult, and like they can at least see us. It'd be better if all these people could have a psychiatrist, because I think a lot of us could, benefit from seeing a psychiatrist, but sometimes that's not feasible. So we can always see them for a one-time consult, and we can usually get them in within a couple of weeks for that. So not as, sometimes, it's better that people have ongoing psychiatric care, but we'll at least see them for one-time consult with then, the whoever's working with the person in the community continuing to prescribe after that. And sometimes we even see them for a follow-up consult, because I've had this happen a bunch, especially since COVID, where we see someone and they perhaps have bipolar disorder, and they just isn't accessing the community. Then we do a follow-up because the OB is still managing them, and that's hard. And we don't expect OBs to manage bipolar disorder by themselves. So that's another, we can certainly do that too. So, and then, so we have another question here. MS3 at Washington University Med, interested in reproductive psychiatry, Meg Gard. Thanks so much for your talk. One thing I've noticed is that women with PPD are also commonly misdiagnosed with borderline personality disorder, or their HPI will say cluster B traits. Do you believe that this comorbidity is rooted in trauma? And do you believe a history of trauma is a risk factor for PPD? That is a great question.
Really, really good question. Really complex answer. I think, I didn't spend a lot of time going into this. The commentary in Health Affairs that I referenced, it actually has a really lovely kind of summary of kind of the way our health system has thought about mental health care is really rooted in pretty racist and sexist ideas about what wellness looks like. And so I do think that there's a lot of problems with diagnostics in psychiatry and the way we interpret symptoms. And for example, I was seeing a patient yesterday who has a pretty clear perimenstrual exacerbation pattern in a very complex and significant mood disorder. But the persistence of her symptoms month by month could be read, if you look at her chart, as somebody with chronic interpersonal challenges. And so you can see how there may be an overlay of a reproductive a reproductive event overlaid on the interpretation of symptoms. And so it really kind of brought that point home. So it's a really, really good question I was just thinking about yesterday in terms of kind of how we would conceptualize this patient from a reproductive psychiatry standpoint as compared to how the world and general psychiatry has conceptualized her up until this point. So I think what's important in thinking about kind of diagnosis is really trying to, one, validate the person's experience and trying to understand it, and trying to also take it at face value. Somebody's describing the experience and try to understand it in that way, and not sort of assume that the prior concerns about personality hold true. Trauma itself is indeed a risk factor for having an emotional complication in pregnancy and in the postpartum. Early trauma, as well as trauma in the context of adult life, or trauma in the context of pregnancy or birth. So all of those things are really important, and pregnancy and the birth experience can also trigger a traumatic reaction from earlier experiences of trauma. So it's all very interconnected. And so having an open mind and being really validating in the clinical encounter is really, really important, I think, from that perspective. Nancy, you may have something to add to that.
No, I totally agree. And I think that we use really stigmatizing language, and we label people, like when we say they're borderline. I think that we need to see this a little bit more subtle, because once someone, like we use that, I think this is what Maggie, the student, is getting to. Like it's really, so just to echoing what you're saying, I totally agree with everything you've said. Yeah, and we have another question. Well, I saw that Gina, one of our team members, responded that we recommend sharing the list with the patient as soon as possible, waiting for follow-up appointment. Yeah, thank you for mentioning that, Gina, because you're absolutely right. Because I think we may send a list, but if we wait a month for an appointment, those therapists might not be taking patients because it moves so quick these days. So definitely, if we send a list, definitely calling the patient as soon as possible is really important. Then we have a comment here. So more, and the person says, more of a comment, it's so difficult to fit everything into a visit. When the whole system is going to recognize that, when is the whole system going to recognize that this pace of care is actually harmful to patients? And each time we engage someone in a conversation about past trauma, and then just move on to the next thing on the list, that we are re-traumatizing people. Well, I agree, Sadhana, Bevan. And I think that it's a real challenge that we have in medicine right now. We've had it for a long time, but it just gets increasingly challenging. So, that you may want to add a comment on that. Not a question specifically, but I appreciate the comment. It's important, and I think we both probably agree.
No, and thank you, Sanjina, for your question. We know each other from sharing some patients in the Brigham system. And I totally, and I happen to know that Sandina is a midwife, and we often talk about at McPat for Moms that sort of the midwifery approach to care being holistic and really thinking about the whole person in a lifespan way is so it can be really helpful in the context of mental health care needs or trauma experiences, and yet you're describing the same pressure and experience that we see all over the place. I will say I totally agree with what you're saying, but I think one of the things that's really that I've learned over time in talking about people's traumatic experiences is, even if you, and in fact sometimes it's actually better not to unmask the whole thing in a moment, but really if you have a short visit or you're just getting to know somebody, simply having an acknowledging comment or conversation saying, have there been experiences that have been tough? I really care about understanding those experiences and making this upcoming experience one that's going to be a positive one, that will acknowledge what you've been through without necessarily feeling like we have to have this pressure of understanding all of the details. Actually understand, talking about all the details can actually be a little bit destabilizing for somebody who's getting into a new treatment care relationship. And so rather than thinking about it as sort of like moving it onto the list, really providing an open validation for that experience may impact care, I think can be really reparative for people to say this is, and that's really trauma-informed care, to say like the specifics of your trauma may actually not be as germane to the conversation, but that I know, I see you, I see that this has happened, and I want to make a trauma responsive approach to the rest of your care going forward. And so I think if we can try to reframe how we think about the trauma, as we acknowledge it's there, but we don't have to kind of go, digging into the details, but really just be empathic and compassionate going forward.
Yeah, I totally agree. And I think, Lena, you mentioned the principles of trauma-informed care. And I think with that, I think people often get overwhelmed, like, how can I add anything else when I have these, like, seeing how many patients a day, but it's sometimes about changing what you're doing and doing it in a different way rather than adding more. Like, right. Instead of what's wrong with you to what happened to you, it's not that many more words, it's just different, So I think part of that, just to build on what you were saying. Yeah. So I think we're just about out of time, unless anybody, I think we probably have maybe time for one more question. If anybody has a question or comment, otherwise we're probably nearing the end here. Let's just give it a second in case anybody has anything else, but we're just about at time. Well, thank you, everyone. Thank you, Lena, as always, for a wonderful talk and for also sharing your professional, personal experiences. And thank you, everyone, for attending. We will be, the recording will be put on the MCPAP for Moms website. If you have any questions, emails, please fill out our survey that you will get over email. And thank you, everyone, for attending. And thank you, Lena, for presenting.
Thanks so much.